Thank you for the kind introduction, Raymond, and thank you for the to the organizers for inviting me to speak to you on the utility of cardiovascular magnetic resonance, or I will use a short form of CMR in cardiac amyloidosis. So I have no disclosures. So in this 15 minutes, I will be talking about a little bit of introduction to cardiac amyloidosis and CMR, as well as how we use CMR for diagnosis, evaluation of complications in cardiac amyloidosis, as well as differentiating amyloid from other causes of left ventricular hypertrophy, and then some conclusions. So I think the previous session has already given us some details about what cardiac amyloidosis is all about. And in brief, this is a disease caused by abnormal extracellular, I need to highlight this word, extracellular deposit of insoluble proteins, okay? So the amyloid proteins will cause expansion of extracellular space, as well as changes in tissue architecture and organ structure, and cell death, leading to impairment of organ function. And as you know, cardiac involvement is quite common and carries a poor prognosis. So the two major subtypes of amyloidosis affecting the heart are AL and ATTR. And it is important, I think, to highlight the consequences of amyloid protein deposition on in the heart. Right, so you have seen what Dr. Tan Li Ling has already mentioned, some of the morphologic features of thickening of the ventricular and atrial myocardium, atrial septum, and the valves. The amyloid proteins can first cause diastolic dysfunction and resulting in restrictive left ventricular filling and increase in filling pressures, as well as systolic dysfunction later on with reduction in ejection fraction. And both these abnormalities lead to heart failure. There are also conduction abnormalities, arrhythmias, valvular dysfunction, pericardial effusion, and importantly also coronary microvascular obstruction causing myocardial ischemia. All right. Okay, so I'm going to talk a little bit about CMR, cardiovascular magnetic resonance. In case some of you are not familiar with this imaging modality. So basically, I'm sure all of you know about MRI, but you may not be familiar that about MRI being used to image the heart, okay? So as you know, MRI is actually a non-invasive imaging modality, and we can actually, with modern scanners and techniques, use MRI for a very comprehensive evaluation of the heart and the cardiovascular system, right? So basically, MRI uses strong external magnetic fields, magnetic gradients, radio frequency pulses to influence the hydrogen protons in the body, right? And we influence these hydrogen protons with radio frequency pulses and so on in order to generate images of the heart and surrounding structures, right? And a CMR study can be performed with or without gadolinium contrast, yeah? Okay, so later on, I'll be showing you some examples of non-contrasted and contrasted CMR studies. So basically, the MRI signal largely arise from differences in three physical parameters of the hydrogen protons, right? So we have a lot of hydrogen protons in the body because 70% of our tissues are made out of water, right? Right, so there's lots and lots of hydrogen protons for us to image, right? So the three basic physical parameters that we rely on to give us this MRI signal contrast, the proton density of the tissue or the fluid that we are studying, and this parameter called the T1 relaxation, which is a process by which the net magnetization of the hydrogen protons return to its initial value, all right? And then the third parameter is this T2 relaxation, which is a process of the relaxation or decay of the transverse component of magnetization. All right, so why am I telling you all this? Because these are the three physical parameters that allow us to distinguish the signals from the various tissues in the body. All right, so that's why blood looks different from myocardium. Myocardium looks different from fat. All right, and that's basically because of differences in these parameters in the various tissues. Okay, so now CMR is able to provide information in a single study. All of these various information which relates to cardiovascular anatomy and physiology can be derived from a single cardiac MRI study, right? So the parameters will include cardiovascular anatomy and physiology and morphology. We can accurately measure cardiac chamber sizes, ventricular volumes and mass and ejection fraction. We can assess regional wall motion abnormalities, evaluate valvular function, measure blood flow velocities and shunt ratios and cardiac output. We can assess myocardial perfusion status. And most importantly is that we can actually characterize the myocardial tissues. And you'll see later on why this is so important in the evaluation of cardiac amyloidosis, right? We can also evaluate the pericardium and assess external, the extra cardiac structures, all right? So all in one study, which takes perhaps 45 to 60 minutes, all right? So you can see why CMR is so useful in the evaluation of many cardiac conditions, all right? So this is an example of a series of moving pictures, what we call cine images of the ventricles from the base here, image number 1, all the way to the apex, image number 10, all right? So these are a series of contiguous slices of the short axis view of the ventricles from the base to the apex. And these allow us to assess regional wall motion, allow us to measure ventricular volumes, measure ventricular mass, and also look at things like myocardial dyssynchrony, as well as evaluate the surrounding structures and so on, right? So this is one of those workhorse kind of series of images that we need and we routinely acquire when we study the heart, okay? So just an example of how useful cardiac MRI can be. Now, I want to talk a little bit about gadolinium contrast because, again, this is one of those important tools that we use in the evaluation of cardiac amyloidosis. So gadolinium is a heavy metal, it's a paramagnetic metal that enhances T1 and T2 relaxation of the hydrogen protons, and thereby reducing the T1 and T2 relaxation time, okay? So when we give gadolinium, the gadolinium contrast that we use in CMR are extracellular agents. So these agents accumulate in the myocardium with expanded extracellular spaces, all right? So what are the conditions that can produce expanded extracellular spaces in the myocardium? You have conditions such as myocardial infarction, myocardial edema, fibrosis, and abnormal infiltration by abnormal proteins. And one of the abnormal proteins is amyloid, right? So when you have cardiac amyloidosis, there is expansion of the extracellular space and volume, and the gadolinium will then enter into the myocardium and accumulate in these extracellular spaces. So tissues that accumulate gadolinium will appear bright, and thereby allowing us to differentiate these abnormal areas in the myocardium from the normal myocardium that do not accumulate gadolinium, all right? So in CMR, we use a particular sequence called the inversion recovery sequence to image the heart after we inject gadolinium contrast. So I just want to show you a little graph just to tell you how this is useful. So when you inject gadolinium, we then take the picture. We use an inversion recovery pulse, and then we wait for the T1 recovery, right? So assuming that this curve here, the black curve here, is that of normal myocardium, myocardium that has gadolinium will recover faster, all right? So if you image at this point in time when the normal myocardium curve crosses this, what we call the null point, right? You can see that there is this signal intensity difference between the myocardium with gadolinium compared to the normal myocardium. And this allows us to then visualize the myocardium that has accumulated gadolinium, okay? So I'm going to give you an example of this, and this is a picture of a patient with a previous myocardial infarction, all right? So we have given gadolinium, and then we have acquired the picture, and the gadolinium accumulates in the infarcted region, which is depicted here in white, okay, with increased signal intensity. The normal myocardium here is black, All right, so this is deliberately acquired to null the signal from the normal myocardium. So you can see that we can tell exactly where the infarcted myocardium is, and more importantly also, we can measure the extent of the infarction and quantify this in terms of percentage of the myocardium that's infarcted, and quantify that also in terms of the mass, in terms of grams, okay? Right, so this is a picture of myocardial infarction. Okay, now let's show some pictures of CMR findings in cardiac amyloidosis, and as already pointed out by Dr. Tan in the echocardiogram section of this series, you can see that the myocardium is thickened, and typically we see that in cardiac amyloidosis there is like a concentric hypertrophy of the left ventricle, right? There is also hypertrophy of the right ventricular myocardium, just as pointed out by Dr. Tan as well. And you can also see thickening of the atrial walls. Okay, so this is the right atrium, that's the left atrium, thickening of the atrial walls and the atrial septum, right? The atria chambers are dilated, and there is also a small pericardial effusion, right? So these are all hallmark features of cardiac amyloidosis, right? So you can remember that I show you the series of short axis slices. So we can use that to measure the ventricular volumes and ejection fraction. And as pointed out by Dr. Tan, in the early stages of cardiac amyloidosis, the ejection fraction is often preserved and it becomes reduced in the late stages, all right? Now, we can do myocardial characterization by measuring the parameters that we mentioned, which is the T1 and the T2 time, right? So we use techniques called T1 mapping and T2 mapping in order to characterize and measure the relaxation time in the myocardium that is filled with amyloid, right? So it's been shown that in cardiac amyloid, the myocardial T1 time and T2 time are significantly increased compared to normal subjects, okay? And correspondingly, the extracellular volume fraction, which is measured from the myocardial T1 time, is also significantly increased in cardiac amyloidosis, right? So I just show you a couple of pictures here. This is normal volunteer, and this is patients with amyloidosis, where you can see this yellowish part. That's all amyloid, okay? So this yellowish part here is the increase in the T1 and T2 time due to the amyloid proteins, all right? But this T1 and T2 time, they are relatively non-specific because there are many other conditions that can cause an increase in T1 and T2 time, such as myocarditis, myocardial infarction, diffuse fibrosis from other conditions, okay? So the hallmark abnormality in cardiac amyloidosis comes when we inject gadolinium, all right? So there are some important features of gadolinium enhancement in cardiac amyloidosis, and this include very high myocardium gadolinium concentrations very early on after injection, right? It's like the amyloid proteins suck up the gadolinium very quickly, right? And we typically see two kind of myocardial gadolinium enhancement patterns. And the first one will be a circumferential subendocardial enhancement. And this is more commonly seen in AL amyloid, right? And then the second pattern that we often see will be a global myocardial late enhancement. And this is more commonly seen in the ATTR amyloidosis, all right? The other features will be altered myocardial and blood pool gadolinium kinetics, where you have very rapid clearance of gadolinium from the blood pool, right? So the gadolinium doesn't hang around in the blood pool long enough, unlike in many other conditions like myocardial infarction, right? So the blood pool will turn black very quickly because the gadolinium washes out very, very fast, right? And you also see prominent enhancement of the right ventricular myocardium and atrial walls. So I show you some examples. This is a picture of the two-chamber view showing you a subendocardial kind of pattern of late enhancement. And this is in the short axis view, sort of a subendocardial and circumferential late enhancement. Right? And this is very different from the myocardial infarction that you saw, which is confined to the coronary territory, right? These two pictures show you the transmural pattern of gadolinium enhancement. You can see that almost the entire myocardium lights up white, and you can also see enhancement of the right ventricular myocardium, as well as the atrial septum and the atrial walls. All right, so this is quite typical of cardiac amyloidosis. Again, a reminder that in myocardial infarction, you also get transmural infarction, but these are confined to the coronary territory, okay, that has been infarcted. All right. So are there ways to differentiate AL from ATTR amyloidosis? There's a group of investigators from London that developed a scoring system called the Query Amyloid Late Enhancement Score. And they claim that this score is able to differentiate ATTR from AL amyloidosis with 82% sensitivity and 76% specificity. Unfortunately, this score has not been well validated. And in a recent meta-analysis, it's been shown that although cardiac CMR is useful for diagnosing cardiac amyloidosis, it is not reliable for classifying the disease. All right. We can use CMR to evaluate cardiac complications of cardiac amyloidosis. And this is one patient here, and you can see there's something in the left atrial appendage. And after we give contrast, you can see there's a little thrombus in the left atrial appendage. Okay, so thrombus formation is quite common in cardiac amyloidosis. We can also use CMR to evaluate pericardial effusion and pleural effusion, as in this particular patient, which is due to the heart failure. Okay. CMR can be used to prognosticate cardiac amyloidosis, and it's been shown that just the presence of LGE, late gadolinium enhancement, confers a worse prognosis in patients with suspected or known systemic amyloidosis, as shown in this meta-analysis. CMR is also very useful for differentiating different causes of LVH, and normally we will have to use a combination of techniques in order to study the heart to come to a correct diagnosis. Now I have to emphasize that the imaging findings on CMR must be combined with clinical history, family history, physical examination findings, ECG biomarkers, and even genetic studies in order to arrive at an accurate diagnosis. Okay, so this is a table of all the various conditions that can cause left ventricular hypertrophy and some of the features in T1 mapping, in late enhancement, and ECV measurements, telling us that we can actually use CMR to differentiate some of these conditions that cause left ventricular hypertrophy. Okay, so there are many advantages of CMR. I just want to point out that one of the most important advantages of CMR is that it is non-invasive and free from ionizing radiation. And we can reproducibly quantify parameters like T1 and T2 and ECV and LGE. And this allows us to follow up patients, right? Particularly important now with the era of effective treatment, okay? There are unfortunately some limitations of CMR, long scan time, repeated breath holds. Patients with implanted devices are still contraindicated at the moment. And the gadolinium contrast that we use is contraindicated in patients with moderate to severe renal dysfunction, okay? So in conclusion, I think cardiovascular magnetic resonance is really very useful for the non-invasive imaging modality for diagnosis and prognostication in suspected cardiac amyloidosis, and also allows evaluation of the extent of disease and complications. And I pointed out that it is useful for differentiating amyloidosis from other causes of left ventricular hypertrophy. And of course, this is important so that we can prescribe the proper treatment. And finally, CMR can be used for follow-up of treatment efficacy and disease progression. Thank you very much for your attention. And I would like to thank the CMR team at NUH for all these images that I have presented. Thank you.